Hi, I'm Mike Loguidice. I'm the new EP here at Arkansas Heart Hospital. It's my privilege today really to talk to you about pulse field ablation. As an electrophysiologist, I'm very excited about this. This has the potential to revolutionize how we ablate in the heart. Okay. So atrial fibrillation is the most common heart rhythm disorder, and rhythm control can usually be achieved with an AFib ablation or pulmonary vein isolation. Current thermal energies, the one I use, heat or radiofrequency, is limited. Long-term efficacy can be as low as 50 to 70% depending on the case. Collateral injury due to conductive heating can also occur. Longer procedure times. In the most skilled hands with the most sophisticated technology, it can take up to 100 minutes. There are a few structures that I want to talk about. The esophagus, pulmonary veins, and phrenic nerves are particularly vulnerable to injury when ablating in the left atrium during a pulmonary vein isolation. So I'm not sure who's familiar with the PVI, but this is a typical case actually done in the Cabana trial. In which a catheter is used to create a shell of the left atrium, and then another, this is, which one? This, yeah, there we go. And then another catheter, this one here, a radiofrequency open irrigated catheter is used to create point-by-point lesions to electrically isolate the veins around the left and right-sided pulmonary veins. We call that a WACA. And you can imagine, depending on the anatomy, that can be particularly challenging. So what is pulse field ablation? It's a non-thermal ablation technology that is historically utilized in oncology. It utilizes high amplitude, ultra fast, we're talking nanosecond electrical fields to create irreversible damage through a process called electroporation. Serendipitously, cardiac myocytes have the lowest threshold of all tissues in the body to pulse field. And it's not dependent on contact force. You don't have to jam your catheter into the heart to create a lesion. It's actually it's dependent on proximity and the strength of the electrical field across the cell membrane. So with this short pulse duration, negligible resistive thermal effect without conductive heating occurs. So why do we care about that? That means the extracellular matrix within the heart itself is preserved even in the ablation lesion set. So here are a couple examples, I think, of the benefit of pulse field. So here we have animal models in which the pulse field on the left and radiofrequency or heat was directly on the right was directly applied to the IVC with the esophagus deviated right there. And with direct ablation with pulse field, we see no damage to any of the structures, as opposed to with RF therapy, we see complete fistulization of both. Now, histologically, we see with radiofrequency that there is, in this lesion set, fibrosis of the nerves and a necrotic core. Compared to pulse field, when we ablate in the left atrium, a nice transmural lesion, and guess what? The artery and nerve are completely preserved in that complete transmural lesion. And with RF therapy or heat, we have coagulation necrosis. As opposed to pulse field, we have a nice lesion set here. Within the myocardium itself, within the ablation, we have complete obliteration of our blood vessels using heat compared to pulse field, where we see preservation of that intramyocardial blood vessel. And then again, we see the benefits here. Because this is contact dependent, all these little crevices are not covered by heat, as opposed to pulse field, because it's dependent on proximity and electrical field. We see a nice homogeneous lesion. So VVAC Ready is actually been the pioneer, one of the pioneers of pulse field ablation technology out in New York. And this paper, published in JACC, took a look at two separate trials that utilized the first in-human use of proprietary pulse field ablation for performing pulmonary vein isolation. Took a look at 81 patients with paroxysmal AFib, and this was a one-shot technology pulse field, meaning 35 millimeters was covered with one specific lesion application. So you needed two two catheters, one to create that shell that we saw earlier and one to do the ablation. So short-term follow-up safety endpoints were used as well as efficacy endpoints. And interestingly, no esophageal temp probe was used. When we ablate right next to, in that posterior wall of our left atrium, it's right there next to the esophagus. But we didn't, and we usually put a temp probe to monitor the temperature in that structure. This was not used in this study. This was pretty close follow-up, only out to 3 months. And so here we see the technology itself. So just focus on A and B. So this is the proprietary catheter that is used. And so we see that it is able to isolate the veins 100% of the time acutely. The one incidence of perforation was actually not even during the ablation itself. Procedure time, I want you to remember the 100 minutes? That's in the most experienced operator's hands with the most sophisticated technology. This is the first time this was ever used in humans, and it was 92 minutes. Fluoroscopy time was a little bit high. And then this is interesting, no esophageal temp monitoring, no injury at all to the esophagus. No phrenic nerve injury, no pulmonary vein stenosis. So some takeaways, this one-shot pulse field technology can be used to safely isolate the pulmonary veins acutely. No esophageal damage was seen without an esophageal temp probe, and ablation can be done rather quickly. So then, VVAC Ready took a look at a more efficient way to apply pulse field ablation with a novel lattice catheter that actually could toggle between heat and pulse field. I don't want you to read everything up there, it's a lot, but essentially he took a look at how this can not only isolate the veins, it could also be used to create that shell too. So we're only using one catheter now. But he also looked at it to create linear lesions. And as an electrophysiologist, one of the most important things I need, one of my tools is something that I can use to go point by point and ablate things like atrial tachycardia, supraventricular tachycardia, atrial flutter in the left atrium. And so these linear ablation lines are really important. It took a look at both paroxysmal and persistent AFib patients, protocolized them to the lines that I mentioned, CTI. All that means is it's protocolized to the pulmonary vein isolation and a specific lesion set. And interestingly, a group of patients had both RF, so heat and pulse field delivered into the left atrium, and a group only had pulse field. And acute safety and feasibility endpoints were assessed. So this is the lattice catheter. It is 9 millimeters, and the entire thing, let me go back one. Yeah, the entire thing is able to apply the energy we're talking about. And so it has a large thermal footprint, totally different than the normal RF catheter we use. It's compressible and safe, and it's able to easily manipulate on tissues in the heart. And so these next few slides, I think, are the most important, and they excite me a great deal, actually. So we have pulmonary vein isolation. You can't really see, I don't know if it's showing up, but pulmonary vein isolation and all the lesions that they were used were 100% successful with just the pulse field. And this is the pulse field only group right here. So this next slide here, no phrenic nerve, no pulmonary vein stenosis. Now, the RF and pulse field combo actually resulted in some 5.6% esophageal injury. With only pulse field, no injury at all. Now, this is my favorite part right here. This is the crux right here. Fluoroscopy time with the pulse field only group, 2.7 minutes. Now, transpired ablation time, this includes the energy application time, is minuscule. I mean, to do a pulmonary vein isolation, 22 minutes. To do a flutter, 2.6 minutes. I think that's pretty remarkable. And so this is actually just an ablation with pulse field. This is the shell of the left atrium I was talking about. They're utilizing this to ablate and isolate the right-sided veins. And I'm not going to play the whole thing, but it's easily manipulated throughout the left atrium and in minutes isolates the right-sided veins. So takeaways, pulse field can be delivered with the lattice catheter to achieve pulmonary vein isolation acutely without significant complications. And I forgot to mention in this, if you only got pulse field, they did not monitor the temperature within the esophagus. And pulse field with the lattice catheter can be used to create those linear lines that, as an electrophysiologist, is crucial to treat our patients. Next one. Lattice catheter is stable in the heart, and it can actually create a once very long procedure, can cause it to be a very efficient one. And I think that this may be the ideal way to utilize pulse field with the lattice catheter. And so conclusions, randomized data with larger sample sizes is needed to make the definitive conclusions, and there are some studies ongoing. And the pulse field appears to be safe and efficacious in ablating in the left and right atrium. We already talked about that. Couple other points, technology is still proprietary, so cost is an issue. Every manufacturer I've talked to is in a race to be the first to market with this technology. And like I said before, I really think it has the potential to revolutionize how we perform ablations, and in 5 to 10 years, I don't think we'll be using RF technology anymore. That's it. And I do have a lot more slides with data, a lot more data, and if you're interested, I can send it to you, but that's all I have.